I also have the honor to introduce Dr. Brian Gross, who is our next speaker. Dr. Gross started his life and training on the East Coast before moving west. He did his medicine and cardiology training at the University of Washington.
Well, yeah.
Medicine at Dartmouth and then cardiology at Washington before joining practice in Southern Oregon almost 30 years ago. 32 years ago. Dr. Gross is actually a recognized leader for management of STEMI and STEMI networks, and a lot of the data for this came from his group in Southern Oregon. And so he is also a great friend of the Education Committee, so we welcome him today. He's going to be talking on a very interesting topic, how to deal with airline emergencies.
Great. Thank you. Thank you. So this topic came up for me. I was on a flight about 2004 or so going from San Francisco to Chicago, and fortunately we didn't have to divert. Just as the pilot pulled back on the throttles and you start your descent into Chicago, a call went out that they needed a physician or an EMT or a nurse, and I wound up getting out of economy, which I was cramping up and clotting up, and raced up to be of assistance, and was a little terrified at what I had to deal with, because it's not like when you run to a code in the hospital and you have all this wonderful expertise that surrounds you. And it turned out that I dragged this guy out of the bathroom. He was just pasty and couldn't talk, and he was having terrible chest pain. And I didn't want to give him nitro because I could barely feel his pulse, but it sounded like an infarct. And long story short, I said, we need to get the plane down. So we got priority landing, and we raced in there to the gate and opened up, and no paramedics, even though they had 30 minutes. And it was a little frustrating because with our STEMI programs, we'd have had the guy open and already, stented by that point. So everybody in the 1011 stepped over us at the exit and walked out, and I dragged him up and put him in a first-class seat, which you could lay back, and finally 15 minutes later, the O'Hare paramedic crew arrived, and they put the EKG on. You could see major ST segments anteriorly, and I confided to the chief paramedic there. I said, this guy happened to be the air marshal on the plane. 38 years old, little hypertensive, and guess what he does to stay awake? He drinks Red Bull all day. He had had 4 Red Bulls that day. So he ruptured a plaque, or perhaps he had taco subo, as we found on the first talk yesterday. But anyway, he was sick. And so as they went out, I said, he's the air marshal, so be careful. He probably has a revolver and a taser. And, he could get a little confused and he might start shooting. He says, it's okay, Doc. This is Chicago. Everybody packs.
This is your captain speaking. If there is a physician, EMT, or nurse on board, please identify yourself to the flight attendant.
Yesterday, they polled how many people were in this conference. There's about 200. About 1 out of every 600 flights will seek medical attention. And I bet you there's a whole number of you in here who have been called to help at one time or another. But 1 out of 600 flights. The good news is most of the people do fine. As with all the talks I do, I have absolutely no conflicts of interest. And you know what? Stuff happens when you're on an airplane. What an incredible picture. So the outline of this will be, we're going to look at the scope of the problem of major medical problems, primarily cardiac issues. We're going to talk a little bit about what I call fuselage physiology. Are you fit to fly? The things that many of you will be asked. I want to go back east and see my grandkids. Can I go? Who should and who shouldn't? What can happen in the air? What are the options available to you in the air? And we'll talk a little bit about the DVT issue, myth or reality, and this has a lot to do with yesterday's afternoon's lecture on PFOs. And what are the legal implications if you decide to leap out of economy and run up to first class hoping you'll get a free ticket? So worldwide, there's billions of traffickers. And This particular article that was just published in the New England Journal was with a company, a research area that looks at 10% of all the world's global traffic, and about 11,000 in-flight medical emergencies were recorded at this place. This happened to be the University of Pittsburgh, which runs a support mechanism for some of the airlines. There were 16 medical emergencies for every million passengers, but here's the key thing. About one major medical emergency per 600 flights, and about 7.3% of them will be a diversion. And diversion is not a simple matter. It is a huge expense, up to $100,000, $200,000 for the airline. Disrupts everybody's plans. If you were planning on being here 5 minutes to go to give your lecture, going to a wedding, going to a graduation, you got to land at a smaller airport. They may not be able to take off on that airplane. I mean, there's major issues if you have to divert. And what if it happens over the ocean? There's no place to land there. So a little bit of fuselage physiology, oxygen, or why you should have stayed awake in high school physics or first-year medical school. Cabin pressure effects on oxygen, all right? Right now, the cabin is usually pressurized on most commercial airlines at 5,000 to 8,000 feet, the equivalent of being at Crater Lake, okay? If you tried to run at Crater Lake, you'd run out of breath a little bit early, but most people are very comfortable walking around, doing their hiking on down to the boat. For healthy people, the O2 will drop, the PO2 drops from 95 to 56. That sounds like a lot, but it's only 4% of the oxygen carrying capacity. But if you're a cardiopulmonary patient, okay, and you start low, you're on the steep part of the oxyhemoglobin dissociation. Here's the normal guy. Starts high, drops just a little. Here's the guy who starts with a PO2 of 70, and look what he plummets. So if you have a PO2 of around 70, you're going to be in trouble at 8,000 feet on a commercial airliner. Boyle's law, another thing you learned about and quickly forgot. It basically says that volume of a gas is inversely proportional to the pressure. So as the pressure drops, the volume gets bigger. As you go up in an airplane, okay, the pressure drops and the volume will expand. Not a problem. You may smell a little methane gas. A lot of people feel the urge to, pass some gas as their gut swells a little bit, gives them a little distension. It must have been the dog, but there's no dog around, At altitude that we fly at, about 30 to 40% gas expansion will occur. So that's not a problem for most people, but I've certainly had problems in the past when I've had bad allergies, get that piercing, pain more when you land than when you take off. But for people who are at risk, and who's at risk? Well, people who have major ear problems, sinus problems, pneumothorax, eye surgery, just recently had brain surgery, still have big chunks of air in their brain. These could be serious problems for these people, could cause a major decompensation. And for people who have air splints, Foley catheters, or people who have a tracheostomy with an air seal, you might want to put water or something in it because it could expand and you could get necrosis of that region. So here's kind of the balloons that are, flying up, and at, 41,000 feet, you get 6 times the volume expansion. Well, we're not anywhere close to that. We're at 8,000 feet, but it's still 30 to 40% expansion. And look at what happens when the cabin attendant brings around the sodas, or more importantly, the snacks. Look at the bags. They're all ready to burst. That's the volume expansion as you're at 8,000 feet cabin pressure. And you can imagine the little kids, how you always want to give that kid something to eat and drink so that they can keep opening the eustachian tube, because when you take off, okay, the cabin pressure starts to drop and the inner ear pressure expands and it pushes the eardrum out, and that's only a little bit discomfort. You yawn or you swallow and it goes away, but when you're landing, that's when you get even more serious problems as the eardrum kind of gets pulled back into the inner ear. And that can be quite painful for some people. Fuselage physiology, the air quality. Low humidity, it's quite low. And for people who already have a Sika syndrome, dry eyes, or who have asthma, and if they're on a long flight and they're not maintaining, lubricant mucus secretions, they could get into trouble. So infectious disease, I had a personal experience with this. My kids went to China in their junior or senior year, and that was when all the H1N1 was going on, and we had a big family big school meeting a week before, and I said, everybody ought to pop 2 Tylenol when they're about 2 hours from landing, because when you land in China, everybody gets a temperature probe when they get off the plane, and one person had a temperature that was up a little bit. The entire school was quarantined for 2 weeks in China. But they were on Good Morning America. And so it was and my daughter taught everybody how to do Michael Jackson's Thriller dance, and they made a great YouTube. So they had a good time. Fuselage physiology with psychology. Okay, some people, it's claustrophobic, they're irritated, they have alcohol, and bad things can happen. Duct tape is an absolute necessity to have on a flight. It starts before boarding. I mean, you've all been there, right? You've got to get there, and oh my God, look at all the people at PDX. I got to get through that line. Okay, then there's the anxiety of going through TSA, okay? They call it aggressive, I call it second base, okay? You got O.J. Simpson racing down to catch that, if you're not on board in 2 minutes, and always it's the last entry site at the concourse, right? Okay. And then when you get there, somebody just got bumped, and this guy's going ballistic, and he's smashing the station where they load you. And then it escalates as you get on am I going to be able to have overhead? So, I mean, your blood pressure's high, your anxiety's high. Am I going to get a seat? Okay. And from snakes on planes. I mean, sometimes you get boa constrictors. And then you really luck out if you get the middle seat, And I don't know about you, you want to get possessive about your space, and suddenly your space is, these are things that in a small number of people can create a significant problem. Then you have the time zone changes. I don't know if I fly back east to see my folks, 3 time zones, and I'm toast. Yet I can stay up 36 hours straight, and it doesn't bother me too much in one time zone. Pneumothorax is one of the most serious things that could get you into trouble. If you had had a rib fracture, fallen off a bike in a bike race, and then were coming back home, and you had an unsuspected pneumothorax, and it expanded another 30 or 40%, you could be in major respiratory distress. The inner ear we talked about. For those of you who do deep sea fishing, when you rapidly haul up one of those fish from deep in the depths, their tongue protrudes, right? This is what happens, okay, in situations where there's a change in pressure. If you have an ileus or a borderline ileus, you just had bowel surgery and decide you want to go home. I'm out of this hospital, I'm going back home. Well, you could get into some serious distension problems there, and people who have had craniotomies, that air doesn't disappear. That'll stick around for a while, and that could lead to some compression issues. So who's safe to fly? Well, these are guidelines where you could feel very comfortable they could do it. If you could walk 50 yards, or you could walk up a flight of stairs. But you and I have both been on planes where there's a lot of people who couldn't even do any of that. But if the PO2 is less than 70, they're going to require oxygen. And the air carrier can't be prejudicial, but it also reserves the right to say, I'm sorry, you're too sick. We're not going to let you on this flight, because it was a major inconvenience if they have to divert. This is one here that's just for reference. It's actually for aeromedical evacuations. But, people who are off on their, bucket list, Amazon, Africa, break some serious bones, get serious illnesses, and they've got to be flown out. These are things that a lot of your paramedic teams on these aeromedical things, and you can look at them at your leisure. But there are some things that they don't want to fly at, or they're going to have to fly at a low altitude, or really lower the cabin pressure so they don't get into difficulty. What about personal medical equipment? A lot of people are on oxygen. They figure, well, I'll just bring my oxygen tank and I'll just go. You're not going to be allowed on there. Remember the Value jet crash? Okay, it was felt to be due to oxygen cylinders, not at this particular type, but that's them searching the swamps of the Everglades for that. And if you have insulin, there's all this stuff with liquids, and they're putting all sorts of restrictions. But you can take your insulin, but you have to have a bottle that's appropriately labeled by the pharmacy in order to get it on and pass security. So now you're up in the air, and that announcement goes off, and your altruistic tendencies spring into action, And pretty soon you go, oh my God, what did I volunteer for? Because you're going to need space. And guess what they don't have a lot of on an airplane? If you're lucky, they're up in first class. Otherwise, you're looking at the galley or you're looking at the major exit. That's the only place you can work. And this isn't going to be your typical ER or ICU. You're not going to have an army of folks come in there to help you. It's you. And everybody's looking at you to come up with the magical answer, and you know exactly what's going on in their lungs and their heart at that instant. And I mean, that picture there in the bottom is very typical of what a fuselage would look like. What medical equipment is going to be available? And it's not totally standardized, but every airplane that has a cabin attendant has to have the following equipment, and they have to have an AED in these days. And there's aspirin. I would disagree with the very first one. They have regular aspirin. I would favor that they'd have baby aspirin. If you had somebody who was having a heart attack, it's a lot easier and more palatable if you chewed 2 baby aspirin rather than a regular adult aspirin. And these people may not, you don't want them drinking a whole lot of stuff there because they're very likely to start upchucking on you, and then it gets real messy in a confined space. And so, but you don't have a lot of drugs. I mean, it's not a flying ICU. It's not a paramedic, aeromedical evacuation. It's a commercial flight. They have stuff, epinephrine, for allergic reactions. They have lidocaine. Fortunately, they don't have amiodarone that you'd have to mix up. And you got 500 cc's of saline that you could give. They've got IVs. They've got, the one case I was involved with, the stethoscope is next to worthless because the drone of the engines, you can't hear anything. So you put the blood pressure cuff on and you just practice good medicine. What's the pulse? You can tell what the systolic blood pressure is very accurate. You don't even need a blood pressure pulse if you just feel it. If the person's got a good pulse, their blood pressure is fine. Nothing that you're going to be dealing with in there. So there are people that have your back. All the major airlines link up with a ground-based support. University of Pittsburgh, which was primarily the author of that recent New England Journal article, it's called StatMD. Their ER is staffed 24/7 with people who are very knowledgeable about fuselage physiology and what the percentage of complaints are that result in a diversion that result in either serious medical injury or death. So they'll help orchestrate, because face it, none of you have ever had any experience with doing this. I certainly didn't. And now suddenly you're thrown into a very unique situation which it's hard to excel at. Don't be afraid to use it. They are connected via satellite phone, and you can run a lot of issues through them, and it kind of helps share that burden. So what's in your wallet? What's in your pocket? I have one of these. I think I had the first one in Oregon. It's basically it's a case that fits on my iPhone, and it gives an EKG. It helps me decide whether they're in SVT or atrial fibrillation, and I could put it on the chest and do a modified lead. And I actually, a couple Sundays ago, diagnosed an arrhythmia in Bhutan from a friend of mine who had one of these and went into a rapid atrial fibrillation. So the globalization of medicine. One of the things that I wouldn't be surprised that we're going to see on every paramedic unit and every airplane is the following: a Google Glass. That's my son, who orchestrated the first open heart surgery down at UCSF. That's the Google Glass guy. And with that, I think we could probably do away with robots that you have for stroke in the emergency room. You don't need the, don't get the right angle. Put it on the receptionist. Google Glass, connect me with Portland neurosurgery or neuroradiology, and you just look at them. Lift your arm. Look at his eyes. Shine a light in their eye. Yep, give TPA. That's a whole lot quicker. I think you'll see it in paramedic units, and that particular device could link via satellite phone potentially to StatMD, and you could get a lot. I think you're going to see a lot of uses of this in the future. So here's the article that was the most recent summary of this coming out of Pittsburgh. And the good news is, if you're asked to respond, is that most of these emergencies will resolve on their own, and they're not serious problems. This is for reference, but basically there were tons of millions of miles flown, 15,000 medical emergencies. There were a total of 14 deaths on the airplane and 16 more deaths after they got transferred to the hospital. So it's a pretty small number, but when you're the person responding, you know, it's pretty scary. And then these are the different kinds of symptoms you might encounter. And what I've done is I've broken it down into all emergencies, those emergencies that result in aircraft diversion and death. And if you look at syncope or respiratory problems, that's what it looks like. And cardiac arrest, oh, there were 22, I don't know, and there were 31 deaths with a cardiac arrest. And then there were cardiac symptoms, obviously chest pain. Interestingly, none of them wound up dying during this 36-month period of evaluation. Possible stroke, none of them died. And you might even have to deliver a baby. So here's another article that came out much earlier in 2002 talking about in-flight events. And you can see that you know, vasovagal are very common. It depends. There's 3 different studies and different proportions depending on how they choose to pigeonhole or silo each of the complaints. The American Airlines, back in the late 1990s, did the first trial with putting an AED on every one of their airplanes. And the results are fairly astounding. They do better than we do in the CCU and in the hospital because our patients are sicker. They have a lot of other comorbidities. But they basically, you know, they went through the same thing. These are people at risk because they're older, they're frail, they're traveling, they're doing time zones, they're stressed, they're low in the oxygen. And they had a total of 14 cardiac arrests during this, and 13 of them were resuscitated. Okay? And the one that wasn't resuscitated, the patient was coming back from Mayo Clinic and had been dealt a terminal diagnosis in the next 2 to 3 months. And when the spouse got her thoughts together, she said, no, don't bring them back. So that's pretty darn good record. That's better than the casinos. If you want to fly some of the European ones, this is a commercial airline. I mean, they have 12-lead electrocardiography, oxygen saturation, direct transmission right to the, I mean, that's kind of where it's going. So what can happen, all right? The flight crew is responsible. You are their guest, you are their consultant, but you don't take over. They'll be happy to share. Make sure you have identification. They always need to know that you are who you say you are. Let the crew kind of run it, but offer suggestions. Get familiar with the medical kit right away. It's not anything that you're going to be able to keep there, but when they open it up, you can quickly see what they got. You'll have to make decisions. Do I need an IV or not? Do I need oxygen or not? And one of the most difficult things will be, do you divert? Because that impacts a lot of things. So what can happen? Well, the unresponsive passenger, you know, they could be vasovagal, they could be a cardiac arrest, it could be a seizure. You know, get the AED on them, give them oxygen, IV access, make sure they're not hypoglycemic. Okay, you could give them D50, you could just yell out, does anybody have a glucometer? And about 30% of the people will give you a glucometer and you could quickly check where you're at. And then you could decide to give the D50. What if you had angina? You know, give them the aspirin, nitro, oxygen. And, you know, asthma, respiratory problems, they do have an MDI there for you. Vasovagal, that's me on the middle fork of the Salmon River when I hurt my back and I got extremely painful and I dropped my pressure. I was with 8 physicians, 3 cardiologists, and nobody could get a blood pressure or a pulse. And I was the color of Dr. Stoll 5 minutes before, okay? And we were a day's float from the nearest airfield, and that's my wife in the yellow, and she's crying, and she's saying to everyone, we don't have enough life insurance. So with vasovagal, autotransfusion, just lift their legs. Keep them relaxed, they come right back, but they look dead. They look as seriously dead or like they're going to die dramatically. Acute allergic reactions, you do have diphenhydramine and you do have epinephrine and abdominal discomfort. You know, if they really get a lot of distension, you may have to lower the cabin pressure or fly lower. Those are recommendations. You're probably not going to tell the pilot to do that, but probably with Med-Air assistance or StatMD. On the people that did render assistance, the physician was about half the time, a nurse or an EMS or other personnel the other time. And in terms of in-flight medical events, there's about 1 every 35,000 passengers. 30 domestic flights a day will have some kind of event. 13 require ground-based assistance. Most of them that the staff can handle just fine. But it turns out that if you divert, you're talking anywhere from $3,000 to $100,000 because you got to get people who missed coming to an important meeting like this, had missed a wedding. You may land at an airport that the plane can't take off on. And what are the indications for diversion? Well, they're going to be the ones where you suspect the worst possible thing is going on. Cardiac arrest, really bad refractory angina that doesn't go away, unresponsiveness, stroke, or severe agitation where they need duct tape. And what about this economy class syndrome we all worry about? This is an article from 1954 or something. And if you take a real careful look, see who the author is. Dr. Homans. Okay, the Homans sign. Remember, you dorsiflex the foot and see if they have pain in the leg. He makes this wonderful comment. There is evidence that persons over 50 years of age should have, in particular, in mind that the physician should be alert to recognize the significance of lameness after an airplane flight, automobile trip, or other occasions of prolonged seating. And it's the old Virchow triad of flow stasis, endothelial injury, and a hypercoagulable state. So some people have actually, there you can see a pulmonary embolus, saddle embolus there, but about 1 out of every 4,646 flights will potentially have a clot form, and about 1 out of every 200 people will have a clot on the day of their travel. More importantly, 27, almost 50 times that number will have it within the next 2 weeks, because clots take time to form and then may break off. So it probably does happen. There's been no successful litigation brought against the physician in Canada or the United States who rendered assistance. Doesn't mean they can't sue, but there are acts of kindness that have legislatively been passed that if you acted within your scope of expertise and you didn't exceed it, like try to stick a cricothyroid, a ballpoint pen in to create an airway and the person bled to death for a vagal reaction, you might be sued. In Europe, if you're a physician and you don't respond, you're in trouble. You're obligated to respond. And you're not allowed to bill the patient. If they want to graciously give you some wine or an upgrade, you're certainly entitled. So anyway, I'm going to turn it over to Joaquin, who had a very interesting thing. You probably read about it in the paper, but he experienced this kind of the ultimate in-flight emergency. Oh, one more slide. So relax, Joaquin. What else could possibly happen?
So the good news is it wasn't one of the pilots, as I think there was a flight from Houston heading up to Seattle where there was an emergency with one of the pilots. So thank you for that great talk. I just wanted to share with you an experience I had in April of last year on my way to a conference in Dallas, Texas. Interestingly, I hadn't been to Dallas since I moved from Dallas 8.5 years ago, and was on my way to a meeting with Judy Workman, who runs our cardiac service line within the hospital. And do you have the... here it is. So I woke up early that morning and was headed to the airport, and as with every day begins with hope. And I said, maybe I'm going to be on a beautiful new airplane, right? There's the new 787, there's the Airbus 380, and maybe somebody is going to check me into not economy coach, but one of these beautiful first-class settings where you can have any of these nice drinks to maintain hydration and these entertainment screens. And so, that's what I always think about when I'm going into PDX. And then reality sets in. And I realize that I'm on American Airlines, and American Airlines uses a 30-year-old MD-80. And it's 3 across. And there really is no Economy Plus section. And typically when I fly, I'm in the Economy Minus section. And that means that you're typically within 5 to 7 rows of the lavatories in the back. And fortunately, I was in an aisle seat. And we were about 45 minutes into the flight, an hour, and we were about 30 minutes north of Salt Lake City. in a oversold MD-80, fully fueled, trying to make it to Dallas, Texas, when all of a sudden I heard an exclamation, and the exclamation was from a woman on the window seat, one row ahead of me, and she exclaimed, "Help, help, my husband isn't moving." And sure enough, her husband was unresponsive. And it really was a frightening moment. I mean, this was complete out, nothing. No air movement, quickly was turning pallorous and blue. And so I unbuckled and moved forward and literally jumped over the person who was in the aisle seat. And quickly took a pulse, and there was no pulse, no air movement. And quickly realized that, one, there's not a lot of space. We're in economy minus section. Two, this gentleman was not small. And although I appear that I'm much stronger than I actually am, I physically could not move him. I was literally straddled over the person in the aisle seat, trying to take advantage of at least my legs where, you know, I'm a runner, and that still didn't work. And a woman who was in the aisle seat on my row leapt up and over, and she looked like she had worked in an emergency room. This woman, with a slight amount of help from me, was able to pull this gentleman and, with my help, get him in that narrow aisle.
Did she release the seatbelt?
Seatbelt was already released. I knew to do that. I thought maybe that's why I can't pull this guy out. And, you know, he was unresponsive, no air movement, no pulse, and so we commenced CPR and quickly asked for somebody to get the AED. And as it turns out, she is a nurse and actually also worked at OHSU. And so we commenced CPR, and they went to the front of the airplane to get the emergency kit, which at that point I actually didn't know what was on it. But what I wanted was an AED. And by the time we got the AED unit opened, he began to have a palpable pulse again, and he returned. And so it must have been about 5 minutes of CPR. And, you know, I don't know whether it turns out this gentleman, so consistent with what you said, I said, we need to, I mean, this was an easy call. It was, you know, need to divert, and we were landing in Salt Lake. What I didn't realize at the time is that we had a fully fueled 30-year-old MD-80, and landing that was not an easy feat for the pilot.
Takes over at that point.
Because the pilot couldn't jettison the fuel because we had to rapidly descend. And so we landed with a fully loaded airplane. Every seat was taken, almost full fuel, because the MD-80 range is not that great. So to get to Dallas and have contingencies, it was completely loaded. And so we came down really fast and hit really hard. And we actually stopped before the gate because I had to make sure that there were no fires from the brakes, etc. And then we were grounded for 2 hours as they inspected the airplane and cleared us to take off. It turns out that this gentleman that was a cardiac transplant, and so this is Candace, who's a nurse, and myself performing CPR in this very small space. And so you actually have to make yourself smaller than you actually are so that you can administer the CPR. And this was the medical kit. We pulled the AED out. And it turns out that Prim is a cardiac transplant survivor. And he was about 10, 11 years out of his transplant.
Twice a survivor now.
And so it's unclear to me whether he actually simply went asystolic, had VT or VF. And he was transported to a hospital in Salt Lake where he was evaluated and wound up with a pacer ICD. And I got to meet him several months later, unbeknownst to me, at OHSU in a ceremony where they were providing awards to different individuals. And Candace and I had received an award, and Judy had contacted this gentleman and his wife, and it was just an incredible experience to be there with him and his wife. As you know, there are about 380,000 out-of-hospital cardiac arrests per year. Survival to discharge without neurologic compromise for all comers is about 10%. And if, in fact, you perform CPR immediately, one can increase the chance of that 3 to 4-fold. And so he is an example of that. And the American Heart Walk, Dr. Evans and a couple of others whom I joined participated in 20 minutes of CPR, AED, shock, conversion back to a rhythm with perfusion, and no neurologic injury in that individual. So we were fortunate that we were able to get him back with good CPR, didn't have to defibrillate him, landed safely in a 30-year-old aircraft, and as you state, many people, as a consequence, missed flights, and they were all thankful to be able to have done that in order to give him a chance to live. So thank you for allowing me to share that experience. It's a little bit different than running a code in the emergency room or in the cath lab, and that's it's a completely different feeling.
You have to do all the things that everybody else does so well independently.
So,
good job.
That was great. Before we open up the questions to the floor, I guess I have a question. Who makes the final decision on the divert thing? Is that the pilot?
Pilot's choice. He has to look at the safety of all the passengers, and I'm sure he was sweating bullets in this one because, and I'm sure they practice that in their simulators, but they have to decide what's going to be safest to put this craft down without injuring any more.
And it's remarkable. You could perceive the difference in the speed, the angle of incline as you came down, how he flared, and then the force of the strike with the tarmac. And you could feel the groan of the airplane as he was trying to slow it down. I mean, it was very different.
Objects in motion tend to stay in motion. Yeah.
And it was not a pleasant approach or landing.
Yeah.
So, Dr. Gross, they want to know what the name of the app was for your EKG.
Oh, this is a live core, and it's a case that runs off the iPhone, and I use it all the time in the office. I save a lot of time when somebody, you want to tell me, they might have atrial fib, it might have PVCs, I just have them sit there with this on while I'm taking a history. It records it, I can make a PDF, I can email it, and it's a $200 case, but I probably use it 10 times a week. If you ask your MA to go get the EKG machine, think of the amount of time it takes, go ahead, hook it up, it's all, waste of time. I can get a rhythm strip on here that is very accurate.
So one of the plans for next year's conference is to have a talk on how smartphones and social media are going to affect our patients' lives. I don't know if you guys know this, but Dr. Gross's son, he alluded to this in his talk, actually works for Google.
Actually, one works for Google, the other works for Doximity and Rock Health. Yeah.
So we're hoping to get them to come and give us a presentation on this next year because they really are at the cutting edge of this new technology. There was conflict of
he had a wedding
to go to this weekend, so I tried desperately because I think it's fascinating and wasn't successful. I can't actually read this, so I have a problem. Use of pocket oximetry and heart rate monitor?
Well, they have devices. I mean, you've seen the Eric Topol thing where they have a little plug-in here that'll give you oxygenation and saturations, and you're going to see a lot more devices that are point of care. And if you haven't seen that Eric Topol TED Talk, that's an interesting one where he goes into a lot of that.
Great. Well, thanks a lot again, you guys.
Good.
Thank you, Brian.